Well, we always do the best we can for every woman, for every person actually, whether they're pregnant or not, or man or woman. We have a very good track record on maternal mortality. We know from the limited statistics we have on suicide in pregnancy in this country, and I don't know if you were here when I presented them, from the masters of the maternity hospitals, that there were none from suicide in a 21-year period. The data was gathered from from 1980 to 2011, and out of 685,000 deliveries, there were no deaths by suicide in pregnancy. So we haven't a lot of information, but we have some information, and we have that crucial information. And so I think you can be assured that women will get the necessary treatment when they are depressed and suicidal. You mentioned something about the north of Ireland and the floodgates, and why is it the floodgates haven't opened there. Well, let's see what happens in the coming weeks now that Mary Stopes has moved in there. What do you do when a woman... Oh, yes, the gentleman here wanted to know what to do when somebody says she's suicidal and wants an abortion. I've seen 2 women like that in my practice. In the Mater Hospital, came in after overdoses. They said, we want abortions. And by spending time with them and talking with them, I ascertained that while they were initially saying they wanted abortions, what was behind the words was they were being encouraged, strongly encouraged, under threats from their partner and parents to have an abortion. And so that's why it's important to, spend time and listen to what women are saying. Thank you.
Dr. O'Keefe.
Thanks very much. I'd like to thank the first speaker for drawing my attention to a point that hasn't previously been raised, which is that death during pregnancy is rare. However, suicide is an important cause of death during pregnancy, even where abortion is available. And in the confidential inquiry into maternal deaths in the UK, which assessed 3 years of deaths, they found that maternal suicide was more common than previously thought, and was a leading cause overall of maternal mortality. So thank you for drawing my attention to that. In relation to the question about abortion after 30 weeks, every effort obviously would be made by obstetric colleagues and by the medical profession in general to save a baby's life if the baby's life is viable, and that's a given. In relation to what Deputy O'Riordan said, I fully agree with him, and I came here as well thinking that the subject of this hearing was in fact about enacting legislation in relation to suicidal ideation. Just in answer to the question that Deputy Duncan asked, I think the answer there is that in the absence of legislation, it is almost impossible to manage these very complex cases. And we've unfortunately seen that with the death of Savita Hanappanavar, since towards the conclusion of when the report was being written. And in relation to the last point made by Deputy Brennan, the assessment of suicide is something that are trained about. Indeed, I've done that again. We're taught about it in our undergraduate career, and it continues through, and in very complex cases we combine the expertise from various disciplines and also from medically aligned disciplines, and we're used to these complex case management conferences.
Thank you. Okay, thank you. We have Dr. McCarthy, and we have 9 minutes remaining in this session. 9 minutes remaining. Sorry.
Just in terms of the first speaker regarding have we as perinatal psychiatrists ever seen a situation where termination of pregnancy has been the treatment for a suicidal woman? And that is just to reiterate in our statement, with over 40 years clinical experience between us, we haven't seen one clinical situation where that's the case with over 40 years experience. So I know Dr. O'Kane would say that suicide is the leading cause of maternal death, but when you look at how rare maternal mortality is, it can be with it's a statistical leading cause because the rate is so rare with 1 in 500. So that's the first point I'd like to make. Certainly the question of pregnancy at 30 weeks. A 30-week pregnancy is a viable pregnancy, and if the baby is induced at that stage, the baby is likely to do very well. And in the Rotunda, we try and save lives from 24 weeks onwards. So 30 weeks is certainly a very viable fetus. In terms of why we're here, and the Deputy Senator Reardon bringing up the question about what is the best approach in terms of the expert report. Again, we've tried to discuss this and look at this because I think you can see from listening to all of us exactly how complex the situation is. In our clinical practice, we regularly see women who are suicidal. Some of them will have thoughts of suicide. Some will have intention of suicide. Some will have thoughts of, I wish I were dead. So what tends to happen, as we can see here today, is that the notion of suicidality tends to get narrowed down to I'm suicidal or I'm not. But clinically, this is not the situation. Clinically, it's a highly changeable situation. A person may have strong suicidal feelings one day, but they may change the next day, or vice versa. And therefore, when you look at what is the best option for legislators, again, as Professor Crown brought up earlier, I'm not a legislator, but certainly I think that the job legislators have is extremely difficult. Because when you try and just even follow what we're discussing here today, I think it's extremely difficult because of all the different dimensions. And another aspect that hasn't been brought out really is that when the expert group looked at, for example, the emergency situation in a medical context, because in an emergency situation, for example, a woman who has had an epileptic fit and the baby needs to be delivered very quickly, speed is of the essence. In psychiatry, exactly the opposite is the case. Someone who is intensely suicidal, that person often needs admission to hospital. It's exactly the opposite to the medical intervention. So the notion of even doing an emergency termination there is just, it's completely obsolete in terms of a person who's extremely suicidal, because again in our practice we see people who, for example, are profoundly depressed, who feel hopeless, who feel worthless, who feel utterly helpless to deal with situations. And in those situations, you can see clearly the intervention is to usually admit them to the hospital, our day hospital, our home care, but it's to support them and help them through that crisis that they're in. It's not to go in and make a decision which is a permanent and irrevocable decision. And that sort of covers the other question with Senator Durkan saying, how do we treat women who present? You can see that our emphasis is really on looking at providing the best care possible to the women we see. Because again, not only does that benefit the woman, but there's loads and loads of research which shows that good mental health care for the woman leads to better child development, better bonding between mother and infant, better infant development, better IQ development, loads of potential benefits. So these are why we strive to provide the best care possible for women. Also, the question that's come up several times, and Deputy Brennan brings up about is there a floodgate phenomenon or the issue of could this happen? But as psychiatrists, we distinguish between assessing risk because we're good at assessing risk. But the other aspect is actually picking out the individual who will go on to complete suicide. In other words, predicting the future. And none of us can actually do that. That can't be done. And unfortunately, that's almost at the core of the proposed legislation. For psychiatrists to say, can you identify that woman where there's a real and substantial risk? Because, as I said, that's for legislators, but even from a mental health perspective, we're good at the assessment of risk, but it's impossible to be absolutely certain about prediction. So,
just a couple of comments. As the three perinatal psychiatrists, we came together to give a joint statement on what we felt was, our position clinically to move forward. And it's very, very important to take the individual lady who presents to us as paramount. She is pregnant, it's her issue, she is an individual. So she may have, we've all come across and assessed many women who have had terminations, and some would have said that that was what they needed at the time, and some continue to have extreme guilt about that, which was already mentioned. But we must remember that it's absolutely individual, and for us, with our 40 years experience, we have never had assessed a woman who has, our management would be to advise a termination, and I suppose for the legislators that needs to be taken into consideration.
Thank you. Okay. Okay, Deputy Timmins, you're next, and we've got 3 minutes remaining.
Thanks. Thank you very much, Chairman. You know, I won't say the conflicted information, but the difficulties that members of your office have in trying to formulate legislation can be demonstrated by what we hear today. And I think it is important, notwithstanding the fact that government have decided to legislate for the ex-case, that we do hear the views on suicide, because it is obviously the issue that's causing most concern. I just want to, most of what I was going to ask has been clarified, but I just want to clarify again the issue made by Professor Keane that in the British study that the leading cause of maternal mortality in Britain, you know, we have the statistic that it's 1 to 500,000. My understanding from memory that the maternal mortality rate in Britain is somewhere in the region of, I think it's 1 to 6,500. So can we just clarify that? If it is a leading cause, what are the other causes? Because I think it would be wrong to give the wrong impression about it. The other thing is that in your submission you mentioned that overall a pregnant compared to a non-pregnant teenager in the US is more than twice as likely to die by suicide. And you reference a US study. Now, I also have information here, and you know, I know that we can all quote scripture that shows that pregnancy, by contrast, has overall a protective effect against suicide, which also references a US study. I just want to know, is the reference that you gave strictly dealing with teenagers, and is there a study that shows that overall that suicide can, or that actually pregnancy, the cause, has a protective effect against suicide? And that's in the United States, another study that's quoted.
And the last speaker, Deputy Creed.
Councillor, and thank you to the witnesses.
Sorry, no.
I will stay within that time limit. Just two brief questions. The current Medical Council guidelines, as I understand them, make reference to the fact that suicide is a grounds for termination that the medical profession have to be aware of. Could I ask, particularly our colleagues with perinatal experience, in terms of case management, and they've referred to the fact already that in their extensive careers of over 40 years combined experience, they haven't been involved in a case where termination has been the appropriate treatment for somebody with suicidal tendencies. Could they perhaps elaborate maybe on case management where suicide is identified as a condition of a pregnant woman, and what the alternative treatment option may be in terms of case management in that particular context, bearing in mind the current Medical Council guidelines as opposed to statutory change that is being contemplated. Could I ask a second question, just briefly? Professor O'Keane referred just recently to the tragic death of Savita Halappanavar. Could I ask her maybe if she might share with the committee the substantiated knowledge that she has regarding the death of Savita Halappanavar, bearing in mind...
That's the matter of an independent inquiry,
that, but bearing in mind the fact that we're awaiting a HICWA, a HSE and an inquest, maybe she might share with us whatever substantiated knowledge that she has.
That wouldn't be appropriate to today's meeting, Deputy. So, and apologies to Senator... But I'm making a ruling, we're not going to discuss it in the meeting. I said, and my apologies to Senator Batchett. Senator Batchett, time is up. Dr McCarthy.
Okay, the first question with regard to it being the leading cause. Each triennial report, these confidential inquiries into maternal death, report every 3 years, and the report 2002-2005, suicide was definitely the leading cause. Now, again, the numbers are small, but the causes of maternal death are small, but you know, it might be 2 cardiac, 1 renal, 1 rupture of an aneurysm. So suicide does come as being the commonest cause in that report and in one of the subsequent reports, particularly if, as you're probably aware, although I think Frascati again referred to the very few suicidal cases. Truthfully, we also know that many cases went to coroner's courts. In general, with suicide, we always have to look at accidental deaths and open verdicts, and we're all aware of women who almost certainly killed themselves in pregnancy, but there's an open verdict. And very often coroners are under huge pressure to do that. And those women have not been spoken about today, but they're a real issue as well, believe me. With regards to the management, I've certainly seen women in pregnancy who have seriously harmed themselves, tried to kill themselves, been suicidal, and as Professor Casey has said, and Veronica, when treated, were better, and what would like to keep the child. I've also seen women in pregnancy who didn't threaten me with suicide, but I knew a week later they were no longer pregnant because they got to the UK. I'd also seen women in pregnancy who have threatened me. One, particularly with a fatal abnormality, a baby with a fatal abnormality that was not going to. She threatened me. I hate that pejorative word. She was desperately seeking a termination of pregnancy. She actually had booked to have it in the UK a few days later. She just was so desperate she wanted it out now. Of course, under the guidelines at the moment, it felt much, much safer to say, well, baby, you are booked to go to the UK. We're not going to do anything today. If the situation changes and she has that termination here, that may be a different issue, but that will be for my obstetric colleagues to decide rather than me, because she won't be threatening to use that awful pejorative word again. So that's just an example of a very broad spectrum of people that we see.
Okay, thank you. Professor Casey, very briefly, if you want to reply, you don't have to if you don't want to.
I didn't think any of the
Okay, that's fine.
direct.
Okay, thank you. Dr. O'Keefe, if you want to very briefly.
Yeah. Just to say, in response to your question about children, yes, it's true for children that UK, both in the UK and the US, that overall a pregnant teenager is more likely to commit suicide than a non-pregnant teenager. A pregnant adult, female adult, is less likely to commit suicide than a non-pregnant adult. And I think if there are specific questions, we have an expert here in relation to child and adolescent psychiatry who hasn't given any evidence, and perhaps she'd want to give some evidence at this point. But my point simply was that adolescents are at a hugely increased risk of committing suicide if they're pregnant. The other point is there seems to be a bit of confusion about the issue in relation to suicide being a leading cause of death in pregnancy. It is a leading cause of death in pregnancy, and it is also rare. And the reason it is rare is simply because all death in pregnancy is rare, and that's the sum of it. In relation to suicide postpartum is the leading cause of death overall. So there are the statistics in relation to that.
Okay, thank you. Okay, as that concludes this session, I want to thank Dr. McCarthy, Dr. Sheehan, Dr. Fenton, Professor Casey, Dr. O'Kane, and Ms. Maeve Doyle for coming this afternoon to us. Thank you very much indeed. We stand suspended until 5 o'clock, promptly at 5 o'clock, please. Thank you. we're going to resume in public session. What's my brief for 5 o'clock now? Who's going first? All right. Okay, we're going to resume in public session. It's 5 p.m. and out of respect to the witnesses who are to come in, I'm proposing we begin in public session. Is that agreed? Agreed, Garmagov. If we could have witnesses to come in, please. I'll be in who's else? Is Fionnuala McAuliffe here yet? No. Thank you very much indeed. I want to welcome everybody to our session, which is resumed in public session. Can I remind members and our witnesses and members in the public gallery and media in regarding mobile phones to be turned off during the duration of the hearings, as they do interfere with the recording of our proceedings. You're all very welcome to our session this afternoon. This is the fourth session that we have in our series of hearings that the Joint Committee will be conducting over the next 3 days to discuss the implementation of the government decision following the recent publication of the expert group report into matters relating to cases ABC versus Ireland. And in that regard, I want to welcome to our hearing today from the Irish Family Planning Association, Mr. Niall Behan, the Chief Executive, from the Institute of Obstetricians and Gynecologists, Professor Harrison, Chairman Dr. Maeve Nivonen, and Professor Fionnuala McAuliffe, and from Maternal Death Inquiry, Professor Richard Green. And I also want to welcome Dr. Katrina Henchin, Medical Director of the Irish Family Planning Association as well. You're all very welcome to our meeting this afternoon. May I begin by reminding witnesses regarding the position of privilege, that witnesses are protected by absolute privilege in respect of the evidence you are to give to the committee. However, if you're directed by the committee to cease giving evidence in relation to a particular matter and you continue to do so, you are thereafter entitled only to a qualified privilege in respect of your evidence. You are directed that only evidence connected with the matter of discipline is to be given, and you're asked to respect the parliamentary practice to the effect that where possible you should not criticise nor make charges against any person or persons or entity by name in such a way as to make him or her identifiable. And members are reminded of the long-standing parliamentary practice, a ruling of the chair to the effect that members should not comment on, criticise or make charge against a person outside the House or an official either by name in such a way as to make him or her identifiable. And with that, I want to welcome again Mr. Niall Behan and ask him to make his opening remarks. Mr. Behan, you have 10 minutes. Thank you.
Thank you, Mr. Chairman. The Irish Family Planning Association is glad of the opportunity to address the committee on this important issue. The IFPA, as we're probably better known as, provides medical services to over 20,000 clients per year. We also, they're mainly contraceptive services and family planning services, but also treatment for sexually transmitted infections and post-abortion care. Through our national network of pregnancy counselling services, we provide information and support to almost 5,000 women and girls experiencing crisis pregnancies. that were either unplanned, unwanted, or developed into a crisis because of changed circumstances. Women use our services because they feel they are currently not in a position to care for a child, or very often another child. Their reasons include financial worries, diagnosis of a serious fetal abnormality, a pre-existing health problem, or relationship issues, or sometimes a combination of all those issues. The IFPA knows from our counselling services that women who choose abortion are from all walks of life, and each woman has her own reasons for deciding to have an abortion. Women's experience of abortions are diverse, complex, and the decision to have an abortion is not one that women take lightly. The experience of the IFPA and of many doctors is that medical service providers in Ireland are prevented from acting in the best interests of pregnant women's health at some points, and that they must navigate some grey areas of law to protect themselves and patients from prosecution. So, as a service provider, we very much welcome the government's decision to implement the judgment of the European Court of Human Rights case in the ABC versus Ireland judgment. Very few of the women who avail of our service do so because of a risk to their lives, but some women do. Women who come to the IFPA in life-threatening circumstances tend to present at a very early stage of pregnancy, before the risk is imminent. So we're not talking about emergency situations with our services. They tend to be women who have serious complications or have had serious complications during previous pregnancies, or have an underlying health condition. And usually they've been advised at some point previously not to become pregnant again, or that becoming pregnant again could impact on their health.
Could you stand behind the mic if you don't mind, just so that people can pick you up? Sorry.
Yeah, okay.
Thank you very much.
So, for example, the applicant C in the ABC case was 6 weeks pregnant when she realised that she had difficulties. These women have taken the decision to terminate their pregnancy rather than incur a risk to their lives or to their health. They are not prepared to wait until the risk to their health deteriorates to such an effect that it becomes a risk to their life. The serious risk posed to a pregnant woman's health, for example, can be for a range of reasons, including heart issues, kidney diseases, oncology, neurology, gynecology, obstetrics, and a whole range of genetic conditions. The pregnancy may also exacerbate the risk to women to a pre-existing condition for women. For example, epilepsy, diabetes, cardiac disease, or some autoimmune conditions, or severe mental illness. The case may be that the risk to a woman's health may be that there's a risk to the woman's health rather than to her life. And from our perspective as a medical provider, it's very difficult. Indeed, we don't see any kind of bright line distinguishing between a woman's life and her health. And indeed, no other country in Europe forces doctors or medical services to make this distinction, the distinction that's made in Irish law, where abortion is only allowed to save a woman's life, but not to preserve her health. Most countries offer abortion on the basis of adverse consequences for women's health as the only way to ensure her full range of sexual and reproductive health services are available to her. For women in these circumstances, the burden of accessing abortion services is placed on the woman rather than on the healthcare system, and I think that's an important distinction to make. Women who make the journey to the UK for medical reasons do so in the context of legal uncertainty, and there's a chilling effect in the current law. And the standard of medical referral protocols may not be applied. Women in this context must leave the mainstream healthcare service. They must make their own way to a private medical facility in another country without the protection of protocols that apply in other situations. And while some doctors make ad hoc arrangements, we know of women who have travelled without medical files detailing their medical history or by a proper referral from a doctor. These women travel outside the state to avail of services that are criminalised in Ireland, a journey that in many cases involves significant psychological, physical and financial burden, a burden that was recognised by the European Court of Human Rights. These burdens fall most heavily on those who are already disadvantaged or vulnerable, those with little or no income, women with care responsibilities, women with disabilities, women with mental illness, women experience violence, or young women, or women requiring travel visas. It's critical that medical service providers, and indeed the women ourselves, are assured by the government that accessible and appropriate services will be put in place, and that women can have confidence in their decision that their decision will be respected, free from discrimination, coercion or stigma, and their full rights will be vindicated. In that regard, the legislation and the guidelines that are being discussed here must not be so complex as to be rendered ineffective in practice. So, as the European Court of Human Rights has said, they cannot be theoretical and illusory. The government must be guided by the expert group's unambiguous direction in that the options decided upon and enacted are effective and accessible. In the words of the expert group, it would obviously be insufficient for the state to interpret the court's judgment as requiring only a procedure to establish the entitlement to a determination, without also giving access to such treatment. And in that way, I've been very heartened to hear the discussions here today that have kind of focused in on some of the barriers that might be there, and the issues around conscientious objection and refusal to care, and the issues around the capacity to provide services. In relation to the issue that has come up as well, in the threat to life by suicide, the IFPA have had clients who have had suicidal thoughts. We have had clients who have threatened suicide, and we have a very, very small number who have followed through on those threats and taken overdoses. The expert group.
2 minutes remaining.
Yeah, and you'll finish. The expert group gave a great deal of consideration to the appropriate legislative and health service response to the risk to life by the threat of suicide. And the IFPA welcomes that the expert group's report gives absolute clarity that a termination of pregnancy is lawful medical treatment, regardless of whether the risk to life arises from physical or mental health grounds. The expert group's approach would place suicidal intent in the context of pregnancy and within the existing health services without stigmatising either mental health or the termination of pregnancy. There's one other issue that I'd like to focus on, which is the criminalisation of abortion. It's our view, and I think it's clear again from the expert group, that legislation to implement the ABC judgment must remove Section 58 and 59 of the Offences Against a Person Act 1861. And we understand that some members of the Oireachtas may be concerned that legislating when that doing this and legislating when a pregnant woman's life is at risk might lead to an increase in abortion rates. It's our view from the thousands of women that we've seen over the years that criminalisation of abortion does not actually deter women from seeking a termination of pregnancy, nor does it lead to lower abortion rates. It's the IFPA's experience that, for our clients at least, that when they've decided to have a termination of pregnancy, that this is a rational decision, and that once the woman makes this decision, she's unlikely to change her decision, regardless of what the legal obstacles are. So her focus very quickly goes on the practicalities of organising and financing the procedure in another country. I'll leave it there for the moment, Mr. Chairman.
Thank you very much indeed. And our next speaker is Professor Richard Green from Maternal Death Ireland Inquiry Ireland. Thank you.
Thanks very much, Chairman. Ladies and gentlemen. The Maternal Death Inquiry, really this, I suppose, is to explain the background to this and to outline the very good healthcare that's available to women in Ireland. The Maternal Death Inquiry was initiated in the 1950s in the United Kingdom and has been reporting there for since that time, and produced many good reports that improve the care of patients in obstetrics. The reasons for Ireland joining the inquiry was very much around the basis of the scientific approach to the ascertainment of maternal deaths. And this was, and also because we could learn more from being part of a larger cohort of patients, or unfortunately deaths of patients. In 2007, we initiated a working group in Ireland to initiate this confidential inquiry, this was supported by the Department of Health and the HSE, the Institute of Obstetrics and Gynecology, and many other interested parties. And the actual inquiry began in 2009. Very briefly, in terms of the definitions around maternal death, we refer to direct death as being those resulting directly from the pregnancy. Indirect death being those resulting from diseases that were present, existing, or developed during pregnancy and were aggravated by the physiological effects of pregnancy. And coincidental deaths are those where the pregnancy was only coincidentally related. Calculating the maternal mortality rates is a very difficult to get at the denominator. So we use what has been used in the United Kingdom, which is basically 100,000 maternities are those women who deliver babies alive or greater than 24 weeks and stillborn. The great value of undertaking this inquiry, I suppose, is that the case ascertainment in confidential inquiries internationally has been shown to detect somewhere of the order of 1.5 to 2 times the number of maternal deaths that are found in civil registration procedures. And there are many reasons for that. But the other values of these confidential inquiries is that they actually assess the causes of death and identify where there are lessons to be learned, where care can be altered or changed, and improve the outcome for women during pregnancy. The comparisons in Ireland, we have carried out comparisons in Ireland with the CSO figures and the relationship of those. So I suppose the important things as a background to this particular discussion and issue is that the figures, maternal mortality in Ireland has been often touted as being low in comparison to international comparisons. And the triennial report for 2009 to 2011, using the scientific approach of the maternal death classification system, identified 25 maternal mortalities. Of these, 6 were classified as direct maternal deaths or associated directly with the pregnancy. 13 were associated as indirect maternal deaths, and the remaining 6 attributed to coincidental causes. During this period, there were some 225,136 maternities in Ireland, giving an overall rate of 8.6 maternal deaths per 100,000 in the 3 years. Importantly, I suppose, from care point of view, there was no clustering in any hospital, and the national and international comparisons are outlined, and I'll talk about them in a moment. There's always, I suppose, caution around this in that this is the first real initiation of this in Ireland, and perhaps there were cases that were not identified, although we've had a phenomenal response to this particular inquiry from the clinicians involved throughout the country, not only in maternity units but also in general hospitals. Comparing Ireland to our nearest neighbours with the same classification system, our maternal mortality features very highly, with about 8.6 per 100,000 maternities in Ireland during that period, and in a similar time period reported previously in the UK, 11.3. There are also, if we look at the international civil registrations of maternal deaths, Ireland again comes out with a low cause of maternal deaths. What are the causes of these maternal deaths? The direct maternal deaths were associated very directly with pulmonary embolus or clot to the lung, and fluid embolus similarly, and multi-organ failure secondary to a condition called HELP associated with pregnancy. The indirect causes included heart disease, cardiovascular disease, influenza, H1N1 influenza, epilepsy, chronic obstructive pulmonary disease, and bleeding esophageal varicose veins, essentially. There were also 2 suicides, and in the case of one of these suicides occurred during the pregnancy, and one occurred in the postpartum period, and after the woman had delivered her baby. Both of those cases were well known to the psychiatric services and under care. The notifications for 2012 have also identified 3 women who committed suicide associated or around the time of pregnancy, 1 during pregnancy, 2 post-delivery, and again, all of them were known to the psychiatric services. I suppose what this identifies very much is that women having pregnancies in Ireland are actually availing of a very high level of health care. And while these figures are inevitably part of the fact that we're a wealthy country, that we're a highly educated population, and that we have excellent health care, I think it's important that women actually understand that in this country they are availing of there are very good results, and I think we need to take away some of the scare and concerns that are out there in the public. Okay. The value of the confidential inquiry is that we have a really good baseline as to one of the markers for maternity care in Ireland, and that's showing that we're doing exceptionally well. Inevitably, in this particular debate, it's very difficult to give. We don't have any information with respect to whether termination of pregnancy has reduced or otherwise those figures. But inevitably, it is part of the total healthcare package that will continue to assist women in hopefully having successful pregnancies. Thank you very much.
Thank you very much indeed, Mr. Green. Thank you very much indeed, Professor Green. And our next speaker is Professor Fionnuala McAuliffe from the Institute of... Oh, sorry, Professor Harrison.
Please, the Chairman, I will make an initial statement and pass over to her, if that's all right.
Yeah, it's 10 minutes, Professor Harrison. Thank you.
Okay.
Very welcome.
Well, I won't take 10 minutes.
Between the two of you, sorry.
I'm Robbie Harrison, Chairman of the Institute for Obstetricians and Gynecologists, College of Physicians. The Institute is the corporate representation of Obs and Gynae in Ireland. To quote our standing orders, its objects are: 1, to represent obstetrical and gynecological opinion in Ireland in a professional, advisory and administrative capacity. 2, to act as the advisory body in Ireland in matters relating to education, training, research and administration in the specialty of obstetrics and gynecology. 3, to promote excellence in the areas of patient care, professional standards, education and research in Obs and Gynae. Now, committee, there are only 120 consultants, approximately, in Obs and Gynae in Ireland. And that number has stayed static despite a 40% increase in births. There are 126 trainees. The Institute has 223 members or fellows, of whom 24 are associates in training. The Executive Committee, on whose behalf this presentation is being made, has members elected from the body from various areas throughout the country, including Northern Ireland. The duration of the Executive and my position is 3 years. So we are the group that really does represent our specialty. Our brief, as stated in the letter, is to make a presentation, and this is what we'll do, solely this, make a presentation on the implementation of the recent government decision following the publication of the expert group report. I'm no longer in clinical practice, although still on the specialist register, and therefore feel it more appropriate that our position be given by somebody who is, namely Professor Fionnuala McAuliffe, amongst other things is consultant obstetrician gynecologist and specialist in maternal and fetal medicine at Holles Street, and she's also head of women and child's health at UCD. To help her with questions is Maiden Ibuinon, sorry, pardon my Irish, who is a consultant obstetrician gynecologist at Mayo General Hospital. I'll try and keep quiet unless my experience of 47 years is needed. Fionnuala?
Thank you very much. Dr. McAuliffe, you're very welcome. Thank you very much.
Thank you very much. Chairman Buttimer, members of the committee, ladies and gentlemen. As we've heard from Professor Green, maternal health services in Ireland are amongst the best in the world, and pregnant women and their families should be reassured that they are receiving the very best of care in pregnancy. One measure of maternal health services is maternal mortality rates that we've just heard about, and our accurate figures in Ireland show that these rates are approximately one mother dying per 12,000 pregnancies. These low rates compare very well with the UK and Europe. Another measure of maternity care is the number of cases of severe maternal illness during pregnancy. These are the numbers of women who, without timely treatment, risked maternal death. Ireland is one of the leading countries to collect this type of information, and the rates of severe maternal illness in pregnancy recorded in Dublin are 3 per 1,000 pregnancies, which compare very favourably with the Scottish data of 4 to 6 per 1,000 pregnancies. However, we are never complacent, and it is our absolute priority to ensure that pregnant women receive the very best of care. In order to maintain these high standards, and indeed to improve upon them, we need to continually adequately resource our maternity services. So some general comments on the report of the expert group on the judgment of the ABC versus Ireland. We very much welcome the report for the opportunity for input and applaud the expert report. It is important that obstetricians have legal clarity when making difficult clinical decisions regarding termination of pregnancy or delivery of a very premature baby, when treatment is required to ameliorate the threat of a mother's life. The situation where termination of pregnancy or delivery of a very premature baby is required in order to avert a substantial risk to the life of the mother is rare, though does occur. The majority of cases that we see as obstetricians arise in women with prior medical disorders, such as severe heart, lung, or liver diseases, or where a mother develops severe pregnancy-related blood pressure. If the baby is delivered at a stage before it can survive, unfortunately the baby dies. However, once the baby reaches a stage when it can survive, it is current practice that every effort is made to support the life of that baby. The test to be applied can only be a medical one, to which exact precision and timing cannot be applied. As doctors, we deal with probabilities and cannot precisely predict death nor timing of death. However, we obstetricians are the experts in maternity care, and if two senior obstetricians, in consultation with the appropriate medical specialties, consider that there is a substantial risk to the life of the mother, which can only be ameliorated by termination of pregnancy or delivery of a very premature baby, then we will take this decision. This is our current clinical practice, and it is imperative that we are allowed to continue this practice in the interests of pregnant women in Ireland. These are complex and difficult cases, and a multidisciplinary team approach is required. However, obstetricians are those clinicians that are experienced in the care of pregnant women, and therefore should be central in the assessment of sick pregnant women and central to any decision-making process when there is substantial risk to the life of the mother. So specific comments on the report of the expert group. Chapter 6, Procedures for Determining Entitlement and Access to Termination of Pregnancy. 6.2, Test to be applied. As already stated, it can only be a medical decision with appropriate documentation. 6.3, Qualifications of doctors involved. In regard to the question of this, it is the view of the Institute that this should be a consultant obstetrician on the specialist register. 6.4, 1 to 4, Number and role of doctors. It is the Institute view that 2 consultant specialist registered obstetricians and gynecologists, plus where the condition under review warrants, but only then, other consultants on their own specialist register as a team assessment. 6.5, Emergencies. It is the view of the Institute that no special provisions are required and that established clinical practice guidelines for emergencies will apply. Location. In regard to question of location 6.6, the considerations listed were acknowledged, but it was considered that all licensed general hospitals and not just recognised maternity units should participate in providing these procedures as necessary.